Okay, so the definition between telehealth and telemedicine. Telehealth is using technology to communicate between the patients, providers, educators. Telemedicine is actually used for diagnostic and treatment purposes. So we're going to kind of focus on telemedicine here. It's been evolving for a while since the internet boom and all that stuff in 1990. Online banking has been there. We all use our Apple Pay and phones for everything. Now there's e-commerce, tele-education, social media. It's basically taking over our lives. So medicine's up next. In terms of virtual things that are being done right now, second opinions are being offered. I'm sure any of your ERs have a stroke protocol where they can, the ERs can talk to a neurologist or a neurosurgeon someplace and get virtual consultations. There's a lot of brand name. People are starting to get into this space. There's also a huge demand from the consumers because nobody wants to go to the doctor's office, sit there for a few hours waiting for their turn in the exam room. So, and the doctors are also not wanting to spend time in their offices, and if they can do it over the internet, the younger generation likes that. The newest thing is that reimbursement is now available for this. It has finally come to that. The overheads are lower for us because we don't have to have office and supplies and things like that. So there's a good reason for this to occur. If you Google telemedicine health providers, you'll get 1,000 hits. Okay, so they already have top 100 lists for these kind of things. The real leaders in this is the VA hospital. They've had over 1.2 million telehealth visits for their 690 veterans. So they're really leading that technology. Teleradiology is pretty common. In my hospital, the overnight Nighthawk service is provided by people in New Zealand. So this is not unusual, but some are taking it a little bit farther where they're actually getting rid of radiology departments. So this is moving along. We discussed telestroke. There are some hospitals where they have robots walking around and you see the patient via the robot. I think Luca Vusi was putting this video together, I think 5 years ago, and he said, yeah, I rounded on my post-op patients through the internet. And the robot is there talking to the patient. It's crazy. In the California prison system, they're using this. And PercuVision Foley catheter allows the urologist to remotely assist in placing a catheter. I think I saw this with Eugene Rhee out of the Kaiser system where he was talking a doc in some remote place in California how to put a catheter in. And it was actually pretty cool. So who can provide the services? Well, doctors, nurse practitioners, physician's assistants, anybody with license to provide care is able to do this. The clinical psychologists have started playing with this stuff as well. The key is the originating site needs to be your usual places where you provide care. Unfortunately, this is not something that you could do, say, sitting here in our meeting now. Okay, this is not a designated site. I couldn't do it from my home or anything like that. So it has to be a hospital office. That's the current way right now. So these are the listed originating sites. That's where you are, not where the patient is. Patient doesn't necessarily have to be in a doctor's office. They can be at home, whatever, but you have to be in your place of service. How is this done? It is not done through Skype or Google, whatever. You do need to use a secure, compliant service. So there are many, many services. If you Google that, you'll see all the different providers. It's probably not worth your time to try and develop a homegrown system. You should just do this through a secure system that's certified. It's different than chronic care management, which you can do over the phone. You don't really need to see the patient and talk to the patient. You can that's a different type of service. Which patients gravitate towards this? Well, it's usually younger, college educated, usually people out in the outskirts. They don't want to take time off work, and it's for stuff that you don't need a physical exam for. But you should examine the patient at some point during your engagement. You wouldn't want to be seeing the patient remotely for 5 years before you ever laid hands on them. This is not allowed. They usually require the same times as a regular visits. 15 minutes is the usual standard. Patients really like it. Why should we do it? They're demanding it. Give them what they want. It does allow you a different way of getting patients into your practice without having to hire a whole bunch of staff and all these kind of things. For those of us who cover, there's not that many urologists, we're all covering multiple ERs. It may be helpful to do this over the phone and do what the neurologists have done for stroke care. So this is starting to occur. And so there are some agreements with hospitals to provide urology care via telemedicine. It's a new service line. Evan just talked to me about doing this stuff on a day where there's so much snow the patients couldn't come in. So he offered it, and the patients paid $50 for each visit, and the day wasn't wasted. You do need to create a business plan. You should have an administrative champion for this, probably a flexible, tech-savvy doctor to be the first guinea pig. The expectations for the patients need to be set, that they're not going to be sitting there for half an hour spouting off about whatever they want. It's 15 minutes, and once that's done, it's done. It is not good for people who are running chronically late. Because these people also value their time. So if your visit's at 2 o'clock, you better be online by 1:59. And everything needs to be set up. You can't be 15 minutes late. That's not going to work. Everything is done by time, so and you need to fit this into your workflow. So if you're running late an hour, you can't just push that off, keep putting that off. You have to choose a software provider, make sure you have good tech support. Most of it is cash right now. Payer specific. For Medicare, you need to follow their rules, which is, it needs to be a rural thing. It's not quite ready for inside the city stuff. What are the reimbursements? You'll have to work that out with each payer. Each one has their own, and there is cash for this, so there are now codes available. The licensure and the liability things are still being worked out in state by state. Most cross-state licensures are not available except in the very rural states. If you're a big provider like Kaiser, where you're multi-state to begin with, it's not as much of a problem. So as the codes come up, you'll have to keep up with those. There is a whole society devoted to this, the American Telemedicine Association. So you'll be keeping up, and I'm sure LUGPA will be right at the forefront of this. Okay, thank you.